Hello, Dr. Lewis, and hello, classmates. My name is Dan Walker, and I'm doing these soap notes for this oral presentation on a patient that I saw on September 6, 2023. Patient ID is modified. Our patient is a 48-year-old Caucasian man who came to the clinic with complaint of itching in his leg and elbows, interior folds that has been persistent for the past 3 weeks. Patient was allowed oriented times 3 and seemed to be a reliable historian. The chief complaint was I'm here because my skin itches a lot at night. HPI, a 40-year-old Caucasian man who arrived at the clinic complaining of itching in his legs and elbows interior folds that has been persistent for 3 weeks, makes it impossible for him to get a good sleep at night. He adds that he spent 2 months living in a shelter with his mother before recently moving into a new apartment. Patient claims that he has no history of dermatitis or atopy. However, he claims he does not use any over-the-counter cream or lotion at this moment, and that the itching and size of the skin lesion have both increased. PMH, hypertension, allergies, no known drug allergies, surgery, medication that patient is currently taking is metoprolol, 100 milligram POQD, and it's controlling the blood pressure. Immunization, vaccination, received childhood vaccine. Last flu shot was August 2022. Psychiatric history, patient deny anxiety or depression. Social history, patient denies tobacco or cigarettes or e-cigarettes or marijuana use. It denies any use of drug, cocaine, heroin, or others. He also denied any use of alcohol. He said because he's a truck driver, he's not allowed to do stuff like that. Marital status, patient is single at the moment. Occupation is a truck driver. Diet, patient admit eating a lot of vegetable and fruit consistently. Exercise, patient reports engaging in physical activity by going to the gym. Family history, patient's dad has history of hypertension and diabetes, type 2 diabetes. Mother also had type 2 diabetes. Patient has a sister and a brother. Sister has high blood pressure, and also the brother has type 2 diabetes. Children, patient has a child that lives with his ex-girlfriend. Review of the system. General, no systemic symptom present at the moment except for the itching of the skin. No chills, no neck rigidity, no weight loss. Skin, patient disputes the existence of new nevi, ulcer, or white or brown area. He claims throughout the interview that he has been scratching a lot at night for the past 3 weeks, particularly in the inside fold of his legs and elbow. Head, deny experiencing headache, concussion, or vertigo. Eyes, no double vision or excessive tear, discomfort, or corrective glasses, or blindness. Here, no changes in hearing, tinnitus, earache, infection, or discharge in the ear. Nose, no running nose, epistaxis, or any sinus discomfort. Throat, no swelling or soreness, or no oropharynx discomfort, no redness, no bleeding gum. Neck, no tumor, enlarged glands, goiter, discomfort or stiffness in the neck. Neuro, there are no syncope, seizure, tremor, paralysis, weakness, numbness, or tingling sensation. Cardio, no chest pain or chest discomfort, palpitation or abnormal heart rhythm. Respiratory, no breathlessness, no cough, dyspnea, wheezing, or pleuritic discomfort. GI, patient deny any changes to appetite or excessive hunger or thirst, jaundice. No nausea, vomiting. GU, no suprapubic discomfort, no hematuria, no kidney or flank pain. Peripheral vascular, no claudication, leg cramps, varicose vein, history of blood clots, abdominal flank, or anything like that. Objective on physical exam, vital sign, temperature was 98.4, heart rate was 78, respiratory was 18, BP was 122/76, SpO2 on room here was 99%. Pain at the moment, no pain. Weight was 146 pounds and height was 68 inches. The BMI was 22.9. Assessed on the general appearance, patient alert oriented times 3-4, speak fluently, currently denies any discomfort in his face or posture, is well hydrated, and there is no elevated temperature. Head, pneumocephalic, no trauma, scalp pink, no tenderness. Neck, no palpable limbs, no a non-sensitive cervical region. Eyes, extraocular movement in both eyes are symmetrical. Pearl. Here, external auditory canal and meatus are normal. No swelling or redness noted. Skin dry, warm, and free of cuts or bruises. There are no ecchymosis, bruising, or suspicious nevi. However, in the inside part of both thigh, the inner folds of the elbow, the knee, and the vesicle are all visible upon view. Additionally, excoriated papules were seen along with crust and mite burrows. Nose, nasal mucosa is pink, wet bilaterally. Inferior turbinates seem normal. Throat, tonsil are not swollen. Neuro, alert, and focus on people, places, times, and circumstances. Cardio, regular rates and rhythm. Heart sound of S1 and S2. No extra heart sound, murmur, or brutes noted. PMI at 5th intercostal space. Nails pink with a normal appearance, no clubbing of the fingernail, no onychomycosis. Assessment. So for this patient, my primary diagnosis was pretty much scabies with ICD code at B86. The reason why I came up with this, my rationale for making this diagnosis to be formulated was because of the patient history that I was able to collect. Patient history was living in a shelter for 2 months, kind of helped with the evidence to support the diagnosis. This is so because scabies spread through skin-to-skin contacts, which could easily be experienced in a crowded place like shelter. So also, visualization of rash, crust, and mite burrow on the skin were helpful to narrowing down the diagnosis to scabies. I'm kind of interested in this patient because of the way I saw it was like a textbook patient, like something that is discussed in a textbook or theoretical. You can see in a clinical rotation. That's kind of what really motivated me to kind of pick up this patient for my clinical, for my oral presentation. So the primary diagnosis is scabies. My differential diagnosis, atopic dermatitis, impetigo, and also folliculitis. I rule out atopic dermatitis because it's more like eczema, and eczema, it's not contagious. So by just looking at this, I know quite well that it's ruled out. So also the impetigo, because impetigo is caused by bacteria, through bacterial infection. So I, like a gram-positive bacteria, I kind of narrowed down to, that kind of make it easy for me to rule that out too. Also folliculitis, sometimes papules and erythematous is seen in a patient that is kind of similar with scabies, but because this is more kind of related with, it's a disorder of the hair follicle. So this kind of make me to rule this out as well. The treatment for this patient, the plan and treatment for this patient, we have two different kinds, the therapeutic and the non-therapeutic. For the therapeutic, I chose permethrin 5% cream, 2 doses. The first dose is going to be used in a week, one time in a week, and the patient was advised to massage thoroughly into the skin from the neck down to the soles of the feet. And it should stay on for about 8 to 14 hours before patient can wash, the cream out of his body. And this exercise can be repeated in 2 weeks by using the second dose of permethrin 5% cream. And for the non-therapeutic, patient was advised to comply with prescription and to use this medication as advised or instructed. The reason is to prevent failure of the treatments. And also the risk of recurrence of the scabies. So patient was advised to modify his place of residence in terms of also avoiding living in a crowded place, and also to refrain from sharing any personal items, with any other person. Also, at the time of therapy, patient was instructed to disinfect his bed, the towels, clothes, and any other personal item. So for referral, there's no test needed. No test needed in this kind of diagnosis. The only follow-up was patient to come back in 3 weeks, just kind of see how the treatment is. Thank you so much, Dr. Lewis, and thank you, classmates. I will appreciate your critique on this. Thank you so much.